Coming up next on Insights on PBS Hawaii, what is the state of mental health care in Hawaii? Aloha and welcome to Insights on PBS Hawaii. I'm Malia Mattoch. Cuts to social services during the economic recession reduced treatment options for Hawaii's mentally ill residents. Meanwhile, heightened workplace stress and a rising homeless population further tax social service agencies. Some believe fewer outpatient options led to more hospitalizations, arrests, and incarcerations. Now that Hawaii's economy is recovering, the state, counties, and social service providers are working to rebuild a mental health safety net. The hope is that patients can be treated before more serious interventions are required. What care is available for those with mental illnesses? What's still needed? Tonight, what is the state of mental health care in Hawaii? We invite you to join our conversation by calling, emailing, or tweeting your questions and comments. Now to our panel. Marya Grambs is the Executive Director of Mental Health America of Hawaii, an agency that provides outreach programs and advocates on behalf of clients with mental illness. Dr. Mark Fridovich is the Adult Mental Health Division Administrator for the State Department of Health. He previously was the administrator for the Hawaii State Hospital. Jerry Kahi is the Clinical Director at the Institute for Human Services, a social services agency that operates an emergency homeless shelter. Jerry is in charge of case management, outreach, and clinical services for guests at IHS. Dr. Jeremy Roberts is a psychiatrist at Kahi Mohala Behavioral Health, the only private freestanding psychiatric hospital in Hawaii. Welcome all. Thank you for coming tonight. Let's start with Mark. Could you give us an overview of what's happening in the state currently with this issue?
Our state is benefiting from economic recovery, and at the State Department of Health Adult Mental Health Division, we've been able to build back from the cuts that occurred in 2008 and 2009. The Adult Mental Health Division is responsible for both population-based services, crisis intervention, planning, and other things that any adult, indeed any person, could use, like through our access line, but also continuing care services for folks that have serious persistent mental illness, adults, and are disabled by that. Over the last year, we've touched about 12,000 people total and have about 7,000 adults in our continuing care population. So that's 7,000. Actually a small fraction of the total number of adults in our state who have serious mental illness. Many people with serious mental illness get treatment, lead successful, happy, satisfying lives with families at school and complete work. But for folks that need help, it's good that our state has been able to build back crisis supports, build back case management services, and provide the needed supports for those individuals.
Let's talk about those cuts. Jerry, you, as you say, have been on the front line. Did you see evidence of how those cuts impacted people on the street, if you will?
One of the things that we notice is our hospital referrals. One way of understanding homelessness saying is that housing equals health care. Mm-hmm. So when people are not housed, and particularly if they're mentally ill, homeless mentally ill people often have a lot of comorbid medical conditions, meaning that they have medical issues to deal with in addition to their mental illness. So in answer to your question, yes, that combination of mental illness and lack of access to health care because they are homeless meant that we've had a huge increase over the last 3 or 4 years in the number of hospital referrals that would be coming into our shelter. Hospital referrals would be coming either from the emergency room or from an inpatient hospital bed for an individual who was unsheltered homeless and ended up needing medical care, and as well from a psych unit, a psychiatric bed.
In terms of seeing it in the private side, did you see evidence of these cuts, and have you seen the impact in the last few years?
Sure. One of the things that that was alluded to there regarding housing is a lot of the patients that are kind of on the edges of doing well and not doing well will suddenly determine that they don't like their homeless situation, will often present to emergency departments or psychiatric hospitals for hospitalization. And the more they can be contained in an outpatient situation, the less likely they are to be coming and utilizing inpatient services that aren't necessarily appropriate. We'll have patients often that there's the term 3 hots in a cot that can exist, and that's not to imply that that's a very common practice, but as well as they can be managed in an outpatient setting, it usually minimizes the inpatient necessity.
By the prevention. Marya, you were the author of Senate Bill 310, or one of the authors of Senate Bill 310, which will dramatically impact outpatient services for some people starting in January of next year. Could you tell us a little bit about that?
Yes, so this is an opportunity for us to get people who are in the community who are very, very ill. They are psychotic. They may be the people you see in the streets who are talking to themselves. They also may be the people you see in the streets who are lying in their own excrement and are having no quality of life. And they are so ill, but they do not know they're ill, so they don't take medication. So this bill, this law, which is now law, enables the family court to actually order a person into treatment in the community. They have to meet several criteria, including going in and out of a hospital or going in and out of prison, being homeless, being gravely disabled, perhaps being a danger to self or others, being unable to take care of themselves.
How would this actually work?
Okay, so say you're a parent and your adult son is homeless, is behaving extremely erratically, and is living in the way I've described. And you're helpless to do anything because he won't take his medication. He won't go for help. So you can go to court and petition the court for an assisted outpatient treatment order. Now, a psychiatrist has to examine your son and make sure he meets all of those criteria, and then develop a treatment plan, which would involve case management, medication, psychotherapy, housing. The judge would listen to the psychiatrist and the family and, interview the patient and say, okay, this person meets the criteria, so I'm going to order this outpatient order for treatment. And at that point, a place will have been identified for your son to get that treatment. And he will either go on his own, you will take him, the case manager will take him, or as a last resort, the police will take him. Once he gets there, he will be offered treatment, but he will not be thrown on the floor and forced to take medication. He can refuse treatment.
So if he declines, he can then leave.
He can leave, but if at that point he is completely out of control and very psychotic, the psychiatrist could call the police and have him hospitalized, but only if he meets the criteria for being hospitalized. And so this is not a foolproof thing, but it will help some people.
Were there concerns about this in terms of civil liberties? What was the pushback on this issue, or was there?
I attended many of the hearings, maybe not all, and I want to say that there was really compassionate and compelling testimony offered. We started off by opposing the bill and ended up supporting it with reservations. There were civil liberties concerns raised. It can be thought of as kind of coercive. And there are many other elements of Hawaii mental health law that look like they're kind of coercive. We ended up supporting it. The biggest concerns we had were just really, are there enough programs to provide for the linkages necessary in order to ensure the success of this kind of assisted community treatment? In states where this has been done and succeeded, typically they have much higher levels of providers, numbers of programs, and higher levels of community funding for programs. And so we asked, and it was taken into account, that there be a little longer time for implementation on the state side. So private providers can begin this through processes to be determined by the family court as early as January 1st, 2014, but the state programs may take until July 1st, 2015.
Could I just say a little bit about civil liberties? Because, we all passionately believe in civil liberties, but when you look at people who who do not have good judgment, do not have the ability to make a judgment about their own lives. It's like, do you have the right to have quality of life? You know, and I think sometimes if people who are concerned about civil liberties went with Jerry out on the streets and talked to some of the people who were there and looked at the condition they were in, they would say, you know, you're not having any humane rights that are being enacted right now.
Jerry, your thoughts?
And at IHS, we so there's a cycle. The cycle, if we talk about relapse is an event that can happen for folks who are addicted to drugs and alcohol. Relapse can happen for folks who have a mental illness. Relapse even happens in our world, in the world that I'm in every day, homelessness. So the counterpart to relapse is recovery. If you look at relapse and recovery as it would apply to mentally ill people, in the shelter environment, almost every day, I often find myself negotiating with a mentally ill person who's been a guest of our shelter, who is not taking their medicine. And because they're not taking their medicine, for whatever reason, they're often not appropriate to be in the shelter, as much as we would like for them to be there. And knowing full well that the consequence of not being in the shelter is that they will be on the street. So I've had the opportunity to see this relapse and recovery play out many times. The good news is that the more often individuals go through this process of relapse and recovery, the fewer times, generally, the fewer times they have to continue to go through that cycle. So the period of maintenance or the period of being functional tends to last longer the more times they go through that relapse, recovery. I think when people consider what would actually happen in implementing this bill, they might tend to think that it's going to be a one-time dramatic event in the life of this individual or this family, when in reality, as our system learns to accommodate the enforcement of this law, and as our service providers and our Department of Health and our health plans orient themselves to really making this work, I think what we're going to see is that this law is going to really support in a more meaningful way that cycle of relapse and recovery. Because just like any recovery, it doesn't happen as the consequence of one event or one intervention.
I'd like to coach that in a slightly different perspective. I mean, we talk about liberties of the individuals, and I understand that, and I value those highly. But the other thing that you have to consider, and what I often face in an inpatient environment, is patients will be admitted, and they will sometimes be violent. They'll sometimes be brought in by police, and they will be brought in on a legal system that allows us to evaluate them. And we can only hold them as long as they're what's referred in the law as imminently dangerous, which means that as it's been adjudicated multiple times, usually within the span of 2 days, 7 days, you think they're going to be dangerous. So we'll get these patients who will be violent and aggressive and a great deal of concern, and they're treated, and all of a sudden they become much more cognizant of their situation. They become much more calm. They're able to interact more reasonably, and they're ready to be discharged. The problem is that they still don't recognize the need for the treatment for the mental illness, which means they go back onto the street. And I can say often that I'm discharging a patient who is currently not imminently dangerous, and yet I'm kind of white-knuckled because I realize these patients in a week are not going to be the same person that they're walking out the door as, and they're going to be a risk to others.
Because of medication.
Because of their mental illness and the lack of treatment that the lack of treatment that will then result in them presenting the same way they presented when they came in. And that's where the bill is so important, is to kind of capture this population, which is a danger to self and others. These aren't just normal people out there and we're trying to grab them and force medications on them. These are patients that are distinct dangers to themselves and others.
Certainly, earlier intervention is going to help a lot. Maintaining a person's recovery, the longer it's maintained, the more beneficial it is for them, and they're achieving maximum of their potential.
But I just want to take a moment to challenge you a little bit about the issue of violence. I think it's on many people's minds right now because there have been so many tragedies. Murders, mass murders committed by people with mental illness. And so I think some people are beginning to think, well, crazy people are violent. People with schizophrenia are killers. And in fact, only 1 out of every 140,000 people with schizophrenia will kill somebody. And in fact, a Columbia University professor studied 300 mass murderers. 80% of them were not mentally ill. So 4/5 were not mentally ill. And in fact, of all violence, 96% are committed by people who are not mentally ill. So, you know, in fact, most people who have severe mental illness are more likely to die by suicide, die by health problems that have been unmet, or be victims of violence. So I think it's so important for us to understand that this is an illness and it's hurting that person far more than it's hurting anybody else. It's hurting their family. And we all need to have compassion and want to do the right thing to get assisted outpatient treatment or inpatient treatment because it's the humane thing to do.
And hopefully this law will help in that. Let's get to some of the questions that have been coming in. From Mohala, is there an outreach program that goes out into the homeless community and screens them for mental health issues and gives advice or counseling to those in need?
We support a couple of homeless outreach programs. I'm not aware of whether we've got one in Mohala or not. We are looking, this is another area where we are rebuilding back from where we were in 2008 and 2009. So yes, there are homeless outreach programs that do exactly that. We need to build more capacity in those programs so they can reach more people, reach more places, and connect those people to continuing support and housing and treatment for their in the areas where they need support.
There are homeless outreach programs. IHS has one. Traditionally, IHS was an emergency shelter and did not have outreach. But over the last 2 years, we have funding from SAMHSA, and we are very proud of our outreach team. When we began our outreach, we were very clear that we had a big job to do, and we limited our outreach area to the urban core of downtown Honolulu, which typically runs from Ke'emoku Street to the airport. In the 2 years that we've had the funding for this outreach, we've identified 249 unduplicated homeless individuals that are in that area. Of that 200 folks, 99 of those people we were able to identify, assess, and do what we hope we can do is bring them into the shelter. The most important thing that our outreach team does is assess for folks vulnerability. What is their level of vulnerability? Is it medical vulnerability? Are they mentally ill? So the answer to the question is yes, there are those programs that exist. However, there aren't enough of them.
Right. And perhaps this would be a good point to mention that for our Neighbor Island viewers, additional police psychologists might be becoming a part of the scene in Neighbor Island communities.
The state has a program that's called Mental Health Emergency Worker, Designated Mental Health Emergency Worker, and on Oahu, they are actually police psychologists that we fund through Honolulu Police Department. We are looking to extend that first to Kauai and hopefully to Maui as well. And the Hawaii County presents some special challenges, again, in terms of providers and geography. But we are hopeful of extending that program, Mental Health Emergency Worker designation, which would be a consultation to the police around taking someone who has need to an emergency room for purposes of being evaluated as to whether they need hospitalization or some other intervention. It's a program that we do want to take statewide. We've made important steps, I think, so far. We need to take it a little bit further, and I'm optimistic about being able to do that through the course of this year.
There's a little bit of a tricky aspect of that, though. And what you'll see is when you work in the emergency departments is you'll have patients who have clearly committed a crime and due to their mental illness. They've assaulted someone or they've been agitated in this manner. And I also want to reinforce that this is not the bulk of mentally ill patients. Sure. This is only a very select and dangerous few that you end up seeing in the emergency rooms and inpatient units. You see some more severe pathology that sometimes can present as dangerous and most of the time is quite benign. But you'll have patients who will have committed a crime. And they're divvied up one way. You know, one group might go to a jail and go through a legal system, and when they go through the legal system, then when they're involved in the forensic system, they can be routed over to the mental health system. They can get the treatment they need, and the courts mandate care, which works for a lot of those patients. But before this bill came about, a lot of those patients would get routed to mental health. They'd be treated, and much like the situation I alluded to earlier, they'd be treated, they'd get better, they'd go out, and then they'd deteriorate again. And so often the police who are trying to be helpful to these patients, were bringing them in for care, in reality probably would have been better served going through the legal system, where there could have been, some degree of control of their behavior after the inpatient admission. Unfortunately, in the civil system right now, where they come to inpatient psychiatric units, there's no way to mandate on the floor if they take medications on the actual unit, and when they leave, there's no way to mandate they take medications. We have a lot of laws in place where we can make sure they don't go if they're imminently dangerous, but at the same time, we can't make them take medications except in particular situations where they're agitated at that particular moment and pose an immediate risk to the personnel or other people. And so, by denying them the legal process, they are actually, in being kind, we're actually providing a disservice. And that would need to change, and that could change through such a bill as has been proposed.
Interesting. All right, from Michael in Kahului, is dementia or Alzheimer's considered a mental health issue? Maybe this is a good point to ask, how do we define mental illness?
Well, mental illnesses, there's a book that comes out, the Diagnostic and Statistical Manual, that comes out every 5-10 years, that is basically a book that helps define what mental illness is, as based on a consortium of a lot of different groups and a lot of input from thousands of psychiatrists and mental health workers. When that's put together, they come up with the technical definitions and the criteria you need to meet to be defined with that disorder. Now, what often is stated in the lay press is, well, you have we're trying to make a disease out of everything. But in almost every diagnosis in the DSM, it has to cause damage to the person. It has to cause educational or family or social strain such that it is actually problematic to the patient. At the point it's not problematic to the patient or those around him, it's not a mental illness. So, for example, you might take me, and I could technically meet all the criteria of ADHD in the world, but the fact of the matter is, I've done pretty well with having met those criteria, and therefore I don't meet that final criteria of causing distress in my life and problematic results.
So in answer to this question, Alzheimer's, dementia,
It's a diagnosed condition in DSM-4, but it's not typically thought of as a mental illness. It's specifically not a condition that we would think of as clinical eligibility for adult mental health services. It's a tragedy for the person and their family, and worthy of our understanding and support, but not typically thought of as a qualifying diagnosis for a mental health system.
Here's a question from Tim in Honolulu. Have any of the panel members been in Waikiki in the last 5 years? Have they walked down Kalakaua recently? The same unbalanced people have been stationed there for several years at the same location. Jerry, you want to take that one? Any thoughts?
Well, for many people, homelessness is a lifestyle choice. For example, IHS receives phone calls almost every week from people on the mainland who are calling to investigate what would it be like for them to come into our shelter because they're contemplating coming to Hawaii and they won't have any resources and therefore they want to come stay at our shelter. We've begun charging folks like that rent because what we've decided is that for some individuals, homelessness is a lifestyle choice, and we have no judgment about that, other than to say that we're going to use the resources, the precious few resources that we have to run our emergency shelter to provide support and shelter for people who are in an emergency homeless situation. The demographics of the homeless population, and I don't want to overgeneralize because I don't know the individuals specifically that this person is talking about, but I'm fairly familiar with the difference in the makeup of homeless individuals in Waikiki versus homeless individuals in A'ala Park. They tend to be two different kinds of people.
Interesting. Explain that.
Well, we have a lot of snowbirds. We have a lot of mainlanders that prefer to be homeless in Waikiki. They often have benefits. They often are drawing their benefits. Although they're in Honolulu, they're able to draw their benefits with their ATM card from wherever they came from. They tend to be more visible as campers. I suspect that this caller is describing somebody who is really mentally ill, however, based on the description that this person gave. And it brings us back to Senate Bill 310. The police are also right there in Waikiki. The police are 100 feet sometimes in Chinatown. The substation in Chinatown is 100 feet from folks that we understand to be chronically homeless and chronically in our face, which I think is part of what the caller is also saying. In the absence of any real threat, maybe that's the word we'll use, but in the absence of any real structure or teeth to a law or an intervention, it's very difficult for the police to dedicate the time and the manpower and the resources when they would bring that person to an emergency room or bring that person to cell block, only to see that very same person right back on that same corner the very next day.
So if anything could be done on that particular issue, any suggestions from the panel?
Well, the state is doing a lot by way of homelessness. The city council, the city of Honolulu is doing a lot by way of homelessness, and I think a number of sets of activities occurring in a variety of different places. It's not a simple problem. We should provide effective treatment to homeless individuals who need it, and we should do that because it's a good thing in its own right. But that alone won't make them not be homeless. They need housing, they need structures in their lives. Some of them are here for a variety of different motives, as Jerry is outlining, that we've got to understand and think through how we're going to work with that. It's not a simple thing. Treatment for the homeless mentally ill, it's a good thing. We should be doing more of it. But that alone, desirable though it will be, will in itself not simply make them not homeless. They need housing. They need a lot else.
That's one of the solutions that Hawaii has come up with, which has been done all over the country. It's called Housing First. It used to be you were mentally ill, you were a substance abuser, you were homeless. You could not get housing until you were cured of your mental illness or your substance abuse.
Clean and sober.
If you're, every night trying to find a place to sleep or sleeping in the rain or not having enough food or, whatever, it's really hard to recover from your mental illness or your substance abuse.
Sure.
So Housing First, revolutionary, right? And it says, we will give you a permanent home. You won't have to look every night for a place. You'll have a shower. And you'll have social services. Every day, somebody will visit you to make sure you're taking your medication. Or there will be social services in your building, so you can have substance abuse treatment, vocational counseling, whatever. So we're starting to develop those in Hawaii, and we have great hopes that that can house a lot of people.
And surely that will help with one segment of the population. However, there's this other segment, which I think you're referring to, who don't necessarily want to change their lifestyle, and that's a harder nut to crack.
There are
right?
some homeless folks.
I don't think it's a harder nut to crack.
Well, there are some homeless folks whose primary relationship is not with a community or a family member or a spouse. It's with drugs and alcohol. So those folks, even with resources available to actually go and pay for housing or to go into a hostel or to go stay at the Y, they're going to, as long as they're relapsing and active in their addiction, they're going to choose the drugs and the alcohol as their lifestyle choice, even if that means that they're going to stay on that corner.
The substance abuse part of this is really important, both for individuals who are homeless and for many adults with serious mental illness as well.
But it's very careful to separate out the homeless and the mentally ill portion. There are a good segment of homeless that aren't mentally ill, and a good segment of mentally ill that aren't homeless.
Correct.
And so,
I think IHS did a study and found that 60% of the chronically homeless had mental illness, and I think it was 40% had mental illness and substance abuse.
yeah, I would be interested on what the instant, not the chronic homeless, but at the instant of any given point, what percentage was homeless, rather than just the chronic homeless. And I think that you'd find a much larger number that wasn't necessarily mentally ill, because there's some kind of transient homelessness that goes on also.
Next question from a teacher. She sees so many angry kids who cannot cope. The school counselors are overwhelmed. What are the options and services available to those kids and their teachers? You've done a lot of work in terms of particularly the problem of suicide among Hawaii's young. Can you address that question?
Suicide and bullying, yes, which bullying might go to the anger issue. But unfortunately, Hawaii is one of the nation's leaders in having among the highest rates of middle school and high school kids who are planning to kill themselves or who are attempting to kill themselves. And it's just startling. In fact, the number of young adults, young people aged 15 to 24 who died by suicide in the last 5 years has doubled. And every year, 7 high school students kill themselves. So we really have a very serious problem of desperate, distraught young people in our schools.
Any thoughts on why that number is so high per capita in Hawaii?
Well, you know, everybody asks this because we've been working with this population for the last 5 years. In fact, we've trained 12,000 youth and adults in suicide and bullying prevention. So we don't have any research to say why, but we have speculation based on what the kids have told us.
Unfortunately, I think there's an intersection with Native Hawaiian, part Hawaiian. Native Americans and Native Hawaiians across our country have the highest rates of adolescent and teen suicide.
And we're actually devoting an entire show to that next week as well. So that you think that accounts for a part of this?
And I think we're told that being on an island, being isolated, being unable to get away is part of it. The large presence of military, kids in military families, they move every year. Their parents leave for war. Their parents may come back and have problems. That's very stressful.
A lot of stress.
Very stressful.
May I make one more comment to the caller's question? Because the caller's a teacher, and the teachers obviously work with parents and talk with parents. And so I'm thinking part of what's motivating this teacher's question is to see the desperation of the parents. One of the common threads that we do see with almost all of the people who come into our homeless shelter is a lack of a supportive relationship with a family member or an absence of family members. When we're talking about children, adolescents, or adults who are mentally ill, they burn out their people. The village can only last so long when an individual has chronic mental illness. And so I wanted to just tell this caller and anybody else that's listening about an organization by the name of NAMI, which stands for the National Association for Mental Illness. NAMI has been in Hawaii for several years, and the core mission of NAMI is to provide education and support for family members who have a loved one who suffers from a mental illness. You can Google NAMI. You can call NAMI at 591-1297. Did you hear me, Malia? 591-1297. And what NAMI has in any given week is between 10 and 15 support groups that are facilitated by family members who themselves have lived through and coped with having a mentally ill loved one, providing education services and support in a group setting, in a class setting. Great. So NAMI Hawaii.
That is a great resource. Thank you.
You're welcome.
Okay, from Philip in Waikiki, what protects the caregiver government from action that exposes them to lawsuits? Interesting question.
Yeah, so it's a complicated question. As long as we, caregivers in general, operate within scope of license or regulation, adhere to community standard of practice, then we're generally protected. Now, that won't stop anyone from making a claim, but generally that's what we do is adhere to community standards, follow regulations, and adhere to policies in the delivery of care and the provision of service.
That doesn't mean that I'm not frightened on a regular basis when I send out someone that is has not done well in the community before, and I suspect long term will not do well in the community again.
Interesting. It's a bit of a quandary.
It is, and as he said, I know I'm protected as long as I've done my job as best I can, and within the scope of my practice. That being said, it's sometimes a little intimidating.
Well, this next question might follow that. From Waikiki, if someone is charged with murder then deemed mentally unstable to stand trial, how long are they kept in a mental hospital? Interesting question
so
for you.
In Hawaii, the standard is reasonable, and as far as I know, there's no definite limit to how long a person could remain unfit to stand trial with a charge like that.
All right. Next question. People in rural communities can't access psychiatric care. Does the panel support properly trained psychologists who can prescribe medication in those areas? From Kalihi. Any thoughts on that?
Well, I would be happy to answer that. I think it's an important solution. We have an utter lack of psychiatrists on the neighbor islands who will, just a lack of psychiatrists, period. But if you're low income, if you're on Quest, there's literally no psychiatrist who will serve you, who will see you. We've been able to get some psychiatric nurse practitioners who can prescribe. We still don't have enough. The Hawaii Medical Psychiatric Association has worked for years to get more psychiatrists on the neighbor islands. They have not been able to. There is a successful program that's been demonstrated in 2 other states and in the U.S. military, which takes clinical psychologists and gives them lengthy training in what's called psychopharmacology, which is medication, and then enables them to prescribe. And we think that is one of the most important solutions and the way we can get help to people in rural communities.
Hawaii doesn't have enough providers. We don't have enough providers really in most categories, psychiatrists, psychologists, social workers, and nurses. And that problem is particularly acute on some neighbor islands and in rural communities, as the question was asked. We need to do a lot of things, explore how all other providers might offer services, and also to look at how technology, how telepsychiatry, telemedicine might help, and how technology in general will really expand the reach of qualified providers to give individuals the support that they need.
Teleconferencing help? if you will?
Like that, yeah.
There's actually, there's actually a program that HMSA is setting up right now that I'm actively involved in, where they're trying to fly psychiatrists out to some of these areas. They see people for their initial visit, and then once the bond is established and a rapport is generated, and you feel like you've had an adequate exam at that time, the continuing follow-ups are done on a teleconferencing sort of basis. And with visits of the psychiatrist once a month, once every few weeks, that may help to fill some of that that lack of care.
Your thoughts, Trey?
With all of our outreach teams, we have a psychiatrist embedded with our team. So when our team does outreach in downtown, we have a psychiatrist or a psych resident that goes along. We also have funding from the city and county to provide outreach on the North Shore. We are doing outreach in Wahiawa, Wailua, and Haleiwa. And we do have a VTC capability. So if there's anybody in Wailua, Wahiawa, or Haleiwa, please go to the Wailua Community Center every Wednesday morning between 9 and noon, and we will have the ability to do a video teleconference with you, beaming you back to our clinic here in Iwilei, where you can speak with a psychiatrist and perhaps get started on some medications or get towards getting a diagnosis.
That's a fantastic resource. Okay, Corey from Maui. Lots of mental health patients are in prison rather than mental institutions. Good point. Let's talk a little bit about that stigma, the criminalization of mental illness. Can we talk about that topic for a bit?
I was just thinking about that, because when you look at the pendulum of what's happening around mental illness, what's happened in the last 50 years, it started with President Kennedy, when we said we can't keep those people in those huge state hospitals. They're imprisoned, it's degrading, they're not getting any treatment. And we emptied those out. Well, now the big county prisons are our mental hospitals. The biggest psychiatric institutions in our country are LA County Hospital, County Jail, Chicago County Jail, and Dade County Jail. So we have, instead of imprisoning them in big state hospitals, we're now imprisoning them in prison. So it hasn't actually improved that much. And so yes, we have criminalized the mentally ill. Hawaii is working with the Department of Justice to improve its mental health services to people in jail. So we're working very hard. The criminal justice system is working very hard to improve services, but that's obviously not ideal. Obviously, people with mental illness should not end up in jail.
But it's probably not going to change radically anytime soon from what I can get from our conversation, or is it?
The largest referral source into IHS from an institution bigger than the hospitals is public safety. So oftentimes, in order for people to leave prison, they have to have an identified address. And don't forget, mentally ill people burn their bridges often, and they don't have family to go to. So often they will come to IHS. The Department of Health, the Alcohol and Drug Abuse Division, I think we're starting to see some people kind of waking up and having more awareness of this, because we now have a contract with the Alcohol and Drug Abuse Division specifically to go into prison to vet, interview, and assess those individuals in advance of them coming into IHS, so that when they land at IHS, we have more of our footing, so that we know how to support that person.
So we do interface also on the discharge, but again, we need to build up community programs and increase stability for an individual that comes out of jail or prison, so that they're more likely to maintain their recovery, and for that they need stable housing, stable program, and health care, and mental health care.
Not to just step out into the abyss, which happens all too often. There needs to be this treatment team ready to help them find housing, making sure that they stay on their medication, make sure they get counseling, make sure they get health care.
Another comment from a viewer, the immigrant community is much more vulnerable and rarely able to access services. Would you guys agree?
Yeah, so another problem with access is both immigrants, recent arrivals, linguistic minorities, again goes to what's our provider capacity? Do we have enough providers? Do we have providers that are culturally sensitive? Do we have providers that are linguistically competent to assess and treat individuals?
Jerry, you see in your shelter, do you see sort of the array of various groups we have in Hawaii? Do you need to sort of not customize, but sort of pay attention to the different cultural aspects of these issues?
We do the best we can. What does that mean? So our family dorm at IHS, at any given time we could have anywhere from 30 to 40 families in our family dorm, which is a total of about 130 people. At the moment, we're at a pretty good ratio of, Pacific Islanders and local people, which makes us feel confident that the Pacific Island folks are finding some place to go be and live and not be homeless. But we are still figuring out this group. We are still, I think mostly if I'm thinking mental health and I'm thinking Micronesian or Pacific Islanders, what I'm looking for is depression. They know that they're at the bottom of the food chain. Their culture is very, very humble. And engaging with that population is very, very difficult, even in an environment where we will interact with them. And of course, this is not, we can't generalize this to every single person, but by and large, our experience in the shelter is that we're still trying to understand how to reach this population. The good news is they're often intact families, so there's a lot of strength to work with and a lot of good places to start. And of course, they're here because they want life for their children to be better. But in terms of understanding mental health issues with this group of people, I think we're really in our infancy to really be a support to them.
Well, one thing, though, is that an agency called Helping Hands Hawaii does have a bilingual program, so it can provide language services when a provider doesn't have those abilities.
All right, good resource. Is someone working on better transportation for the mentally ill? The caller wants special vehicles, something more humane than a police car and handcuffs. Any thoughts on that?
Well, it depends on what type of transportation you're talking about. If you're talking someone who's just on the scene of a crime and coming in, that's very different than someone who's coming in for a clinic visit, which almost never involves handcuffs and police vehicles. Police vehicles and handcuffs are only used when it's thought that to not do so would serve a certain danger. So I very rarely have seen police vehicles involved in anything except for ER visits.
I would say the biggest transportation problem is on the neighbor islands. And before the mental health cuts in 2008, there were subsidized transportation provided by the Department of Health, and those have gone away. So we get told over and over again that people in, in Maui and Big Island and Kauai cannot get to their appointments.
Any discussion on bringing those back?
Yeah, we've talked about it. Next to housing, it's a big issue. Yeah. Maui, Hawaii County, also Kauai, even parts of Oahu. And it's a challenge. It's not clear to me how to go about it. We've really tried to focus on programs. Transportation, not our specialty. Probably not something we would do terrifically well.
Did you
I don't know.
Subsidize it? I think you...
Probably, but we are concerned about it. We're talking with people, listening. We probably have to partner up with county government and local regional transportation entities to make arrangements. It's this issue, we've heard it, we're sensitive to it. It's a little bit of a challenge to figure out how to do it because the logistics are tough. And again, we might not be the best agency to arrange it, but we are sensitive to it and we are very concerned. People have to get to certain places to get the support, they need.
Go ahead.
No problem. I would say, they're speaking from the state side, from the commercial insurance side, or the various Medicare or Medicaid plans. There are, I believe all the Medicare programs are actually mandated to provide transportation, if I recall. And in fact, I've been really impressed at times, even at times where I've had to ship someone over back and forth once a week for certain things. Those particular groups have been actually very responsive, and they're there. Some of the commercial insurances, sometimes a little bit more lagging. You have to push and prod a little bit more. But I would say from the non-state side, they're pretty good about flying people out.
Yeah, I think that's a different question than just, getting to your appointment in Maui. I think I'm really glad
You're
to hear
right.
that. I'm
You're
really
right.
glad to hear that, though.
Overall, let's talk about insurance a little bit. What sort of challenges do you see for the mentally ill in terms of insurance coverage?
I see huge problems. I mean, once you get past the stigma effect of people seeking medical care for mental illness, getting them to the appointment in the first place, you see some of the insurance companies be very strict with what they will actually provide. And in fact, one company that I think of in particular has a particular tendency to burden down the physician with so much work, extraneous work from actually caring for the patient, that it makes it virtually impossible to see the patient. And I don't want to use the word nefarious, but I do. It's systematically designed to limit access. I can think of one of my colleagues that actually said that when there was a transfer of care, when TRICARE patients were transferred from Tri-West to UHC, she sent in a packet of 30 or so patients and authorizations and went through all that effort to hand a packet over to these people. And they said, "We're sorry, we can't accept it when it's bunched together. We have to get them one by one." Or I had another occurrence where they were asking me about a medication that you can only get with a special license, and I can only prescribe it for a certain thing. And they made me be on the phone for 20 minutes solely to ask me if I had the right prescription that I couldn't have prescribed without that prescription, and for the purpose, that's the only reason you can prescribe it. So again, the purpose was simply to put up time obstacles to prevent care being provided. Now, getting things like prior authorization, I don't have a problem with it, and some insurances use it very wisely and will encourage you to use cheaper medications rather than more expensive ones, which is really having a fiduciary duty and being reasonable about the whole thing. But then you get companies like United Healthcare and Optum Health who just seem to have obstacle after obstacle. And the few patients, when I transferred with TRICARE, I couldn't see any of these patients anymore because of the obstacles I've had. I've been on the phone 3 hours at one time. And none of the patients could get other providers. So when I was trying to facilitate them getting to see another provider that could accept their insurance, none of them could find it.
We're working and living through an environment where insurance is changing a lot and quickly.
Daily.
Early this week, we have the implementation of the Affordable Care Act, and more people in our state will be covered with some kind of insurance. It's too complicated, but things will get better, I believe, and this will be a good thing that individuals are covered. We need to simplify insurance, simplify the insurance from the perspective of the provider and from the perspective of the individual getting support and services.
But we do have a concern with the Affordable Care Act and the new connector, because the insurance companies, the plans, do not provide services for severe and persistent mentally ill people. They need more than just an occasional psychiatric visit. They need a case manager, they need some kind of supportive housing, they need maybe a day program such as Clubhouse. They need help with employment, so they need an array of services. And right now we're able to provide those to our Medicaid population and through adult mental health. But at the connector, those won't be available. So if you're a severely mentally ill person and you don't qualify for Medicaid, you're going to fall through the cracks. And so we're working with the connector and with adult mental health and with the insurance providers so we can try to see if we can close that gap and make sure that that population gets the services it needs.
Any thoughts on the Affordable Care Act and how it will impact the population you see?
I guess my comment would be more specific to the landscape here. My job every single day is to support clinicians, nurses, case managers who are trying to link people to a healthcare benefit. And I've also been watching very closely over the last 5 years. I worked for a health plan. I opened a brand new health plan several years back and watched how it worked. Health plans are in it to make money. They have a term called medical expense management. What I know from sitting in the chair that I sit in now, working in the ways that I work now, is that it is almost incomprehensible that a health plan, understanding the potential medical costs for neglecting a certain subset of their membership, have not done a better job of reaching out to the provider community, the local provider community, who is really in a position to help them manage their medical expense. But ironically, they don't do it. That would be my observation.
So I think Jerry raises a good point. Maybe if I could expand on it for just a minute. I think in the long run, the good providers, the good insurers will understand it's to everyone's benefit to enhance the services that are offered on the community side. That'll keep people healthier, and it will help control costs. We work and we're living and we're getting our own supports through a complicated, changing environment, but I think things will get better.
This is from Patricia in Maui. Explain why Maui Mental Health doesn't accept new clients. Caller says they only accept people in trouble with the courts. I'm not sure that's something anyone here can specifically answer, perhaps.
Yeah,
but
I'll try.
Okay, yeah.
Part of the economic challenges for our state and its state government had us restricted in terms of hiring, and specifically hiring at our community mental health centers. For a variety of reasons, we haven't been able to hire. We're beginning to move that now, but the capacity limits on people going into Maui Community Mental Health Center really was related to an inability to hire. I'm fairly optimistic we'll be able to make progress on that in the next interval.
By interval, any sense, are we talking, I know
Months.
it's months.
Yeah.
What other changes might we see in the next few months? There are some other categories of people that might be getting some additional coverage and help, right?
Yeah, again, back in 2008 and 2009, the Adult Mental Health Division restricted its eligibility, and we're working through the public process for changing that back to extend our eligibility to individuals who have severe post-traumatic stress disorder, substance-induced psychotic disorder, and major depressive disorder, severe but without psychotic features. I think it's important public policy that we move in that direction. I think these are people that need our support and can benefit from the specialized services that adult mental health either provides or can arrange through its contractors. This will also bring us in alignment with MedQuest in terms of their eligibility criteria for folks receiving services through their community care support system. So I think it's a good thing to do. It's not done yet. We have to work through a public process. Our eligibility is controlled by Hawaii administrative rules. And besides my seeking authorization, there's a period of time and a process for that becoming changed.
We're down to our final minutes. Let me get in our last question, and then perhaps we can get some final thoughts. Caller and lady friend are receiving psychiatric services and receive $710 a month each from SSI. If they get married, they will lose $200 a month each and become homeless. What is the logic of this cut? From Bobby and Waianae. Any thoughts?
This has to do with SSI.
We do not know.
It's a great question, and it sounds unfair.
We would say there is no logic, but it's not.
I would be happy to marry them in an informal wedding ceremony.
That is the
Benefits
answer. That's a generous offer. All right, in our final minutes, let's just have a quick thought from everyone. What would you like to see in the next few years in terms of improvement? If you could wish one improvement upon the system, what might it be? What's of particular importance?
I would wish that the stigma of mental illness would be changed. I'm somebody who's lived with mental illness my whole life. I've been hospitalized. I'm on medication, and I am okay.
Leading a productive life.
I'm
and
leading
it's
a
very
productive
possible.
life, yes.
Okay.
And so I would wish that that other people didn't have to be ashamed. People didn't have to be so ashamed that they wouldn't even get help, and people wouldn't be afraid to support somebody with mental illness, so that our society would have more compassion and more support and understanding for people with mental illness, because it's an illness. It doesn't mean you're a bad person.
All right, thank you. Jerry.
The topic of our show tonight is mental health. And one of the things in my corner of the barn in terms of homelessness that has really brought down, I think, in a very significant way, the collective mental health of our community is this very, very visible trend of sidewalk campers, homeless folks. I know that it affects me. I'm used to it. I see homeless, deal with homelessness every single day. One of our mission statements at IHS is that we believe that everybody has a right and a responsibility for safe and clean housing. And so as the new year dawns and we have the Caldwell administration who adopted and improved the Carlisle administration's sidewalk ordinance, I would ask people to really think about what it means to not have to drive through the streets of Honolulu anymore and be confronted by and for people to really educate themselves about what is the ordinance, who are people camped on sidewalks, what really are their needs, and what are their responsibilities.
All right.
Earlier intervention makes a big difference, and a message of recovery. Mental illnesses, severe mental illnesses, minor mental illnesses can be treated successfully, and people recover from them. If families, neighbors, co-workers, everyone just is sensitive to that and supports a person needing help, getting help earlier, that'll be great.
Your thoughts, Chairman?
Those are all very noble. Mine is more punitive. I would like to see. I would like to see some of the insurance companies that are really limiting access to the mentally ill, the ones that I have to fight with to keep a patient inpatient when it's clear that they need it, have to have some sort of responsibility to actually be responsible to the patient rather than to their bottom line. Be that, I've thought about nice things like them being able to bill them for my time to make it all of a sudden more expensive for them to just put these barricades in our way, or at least some responsibility for their patients.
All right. Made me smile at the end. Thank you. You've been a great panel. Thanks very much, you guys. Next week on Insights, Native Hawaiians with mental illnesses have a unique set of challenges. How can we help Native Hawaiians whose mental illnesses are compounded by a loss of cultural identity? On the next Insights, what are the mental health challenges for Native Hawaiians? Our guests will include filmmaker Kristen Marquez and Kumuhula Vicky Holt Takamine, founder and executive director of Pa'i, a Native Hawaiian culture and arts organization. That's next time on Insights on PBS Hawaii. I'm Malia Mattoch. A hui ho.